Good day, all, and welcome to the Teledigm Pulse podcast, your rural health matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
This episode is part one of a two-part episode. We had a great conversation with Dr. Ryan Martin from Nebraska Pulmonary Specialties, and we kept the recording going. We're happy to bring it to you in two pieces. We think you'll enjoy it. Be sure to follow up in a couple of weeks where we present part two. Welcome to the Teledigm Pulse podcast. Today's episode, Shane, we've got a pretty exciting guest with us, somebody we worked with for quite a while. Anxious to hear what he has to say.
You're spot on there, Andy. I'm excited today. One of our long tenured physicians with our program, and Dr. Martin. I don't know how far we go back, but it's quite a ways. So I'm delighted that you've taken time out of your busy schedule to spend some time with us there on the Teledigm Pulse podcast, and looking forward to sharing this next several minutes with you and discuss the pulmonary critical care programs that we've put together over the years. So without further ado, would love to introduce Dr. Ryan Martin. So Dr. Martin, if you'd like to share a little bit about yourself, introduce yourself, and we'll kick it off.
Absolutely. Thank you, guys. First and foremost, thank you for having me on. And I'm excited to participate and actually talk a little bit about what we've been able to accomplish, what we've been able to do over the last several years. I believe our program started at the end of, I believe, 2016, if I remember that correctly. But it's been several years now, and we as we started this out, I'm sure you remember it, but we started with one, as does everything. It always starts with one single opportunity, and we just have been able to make it work from there. I'm Ryan Martin. I'm a pulmonary and critical care physician, pulmonary critical care boarded physician. We are part of a large group. Our group runs the entire gamut of the specialties. So we do everything from intensive care unit, in-person care in acute care hospitals. We cover 3 separate acute care hospitals in person. We do general pulmonary floor type medicine. So we do a lot of procedures. We, typically speaking, in our specialty, that's going to run from things like thoracentesis, draining fluid from around lungs, some invasive procedures such as bronchoscopy. We'll do chest tube insertions, occasionally some intubations. There's a wide array of procedural capability within the group. We cover long-term acute care as well. Again, that's another one of those items that our group is experienced at, and have run 2 separate long-term acute care units. And we are, again, when we talk about telemedicine, this started out as a single opportunity, but we have over the years grown this into something that's been a very big portion of our practice. And being completely honest, it's one of the more enjoyable parts of our practice. And really, like I say, we're just thankful for the opportunities that have come up. I mean, if you look at where we started this out as, it was really some colleagues of ours that were down the road about 100 miles in need of some call coverage because they were a couple guys doing it by themselves. And 182 nights of call in a year really turns into be a pretty significant cramp on the lifestyle. So we started, kind of there to just help them out. But the vision was obviously not completed at that point. It was just sort of a place to start by getting your toes wet. And what do you do? Where do you go? And how do you grow?
One of the things I think that was very interesting and intriguing with you, Dr. Martin, when we first got together, going back eight-ish years ago, or that, and then was really where you came from, and your background and your history with rural medicine, and your dad, and I recall a story about stitches and how you received stitches. I don't remember exactly how the story was, but maybe you could share that, just a little bit of your background and your desire to really get involved and help rural healthcare institutions.
Absolutely. So yeah, sometimes it always helps to know where someone comes from. I am a 3rd generation physician. So it is one of those things where we can go and look on the wall at the Nebraska Medical Center, and you can see three generations of us. There's more than three of us. There's actually about 7 or 8 of us. But I grew up in a small town. My hometown is Wayne, Nebraska. My father still practices there. He does family medicine. My grandfather is 90 years old. He is retired from the field, barely. Has done this for years. He was in Pender, Nebraska. The two towns are about 25 miles apart. Um, as I was a younger kid, obviously I, come across injuries as little boys will do. My grandfather gave me my first set of stitches and my first cast. My dad got the second set on me when I was about 10. So it's been a little bit of a family business on this one. Uh, aside from that, though, you kind of grow up with it. So I was always around it, always saw it. Uh, saw the lifestyle, saw the way that they worked, what they did, how much they could do. Um, and what's really another one of those things kind of interesting about growing up with this, and some of where, again, we sort of mentioned how we started, but one of the things that is important to understand about rural communities is there's a point that a lot of times has to be a decision tree of, is this person going to stay with us or is this person going to go? And the house that we lived in Wayne, Nebraska, was actually across the street from the hospital. And I would know, my dad, if he got called, he would walk across the street and go into the emergency room, and he would be there for a while. And then pretty soon the helicopter would show up from time to time. And really, part of this again kind of comes down to knowing what we saw with that, how these were handled. Part of what we really adapted, especially over time, was how can we really help that situation? Obviously, the nature of pulmonary critical care is a lot of, acuity, right? We have a lot of critical care, but there's still stuff that we have to offer that goes deeper than or beyond just the intensive care units. One of the places that I think really gives us a lot of opportunity, and really where our program, I feel like, blossomed significantly.
Yeah, and I can't agree more. And certainly out of the gate is our missions obviously to find ways to increase access to care in rural communities and in large communities, and in particular larger systems trying to help rural hospitals. But certainly the pulmonary critical care was sort of the initial. The initial venue that was the initial playground, if you will, of where we started. And to your point earlier, Dr. Martin, where you had two of your colleagues that basically went into administration and said, "Golly, if you don't get us some help, we're going to leave." The
Right.
the work life balance demands are even. This was starting, eight-ish years ago already in terms of the demand, and those guys were busy folks. And so we had a call from the administration that said, "Golly, what can you guys do? Do you offer EICU, or do you offer more of the comprehensive visit queue, or various technology integrated systems, and what's the expense with that?" And in talking with the local physicians, not only the hospitalists but the pulmonary critical care physicians that were there, the interest wasn't so much in fancy monitors and real time monitoring of the patients. They had a quality nursing staff. What they wanted was um, a consultation. They wanted a pulmonary critical care physician available for their patients at the bedside, and for the nurses to chat with, and the patients and the families, to be there in essentially the same capacity that they were, albeit virtual. And so that's really where this all started, and it's really more from there, to your point, into the critical access hospitals, which we'll touch on here in just a little bit. But maybe you could give some background, as you recall, how the program has morphed over the years. But I remember the early conversations. Do you think we can really do this? Can I really, you still work in these critical care environments, boots on the ground today, but can you really get an adequate, comprehensive physical exam completed in a critical care unit to the point of satisfaction, to then be able to offer life-saving and life-directing care and comprehensive order management, hemodynamic management, vent management through these systems? And maybe kind of describe what you've learned through that over the years and your initial experiences, and you've done hundreds and hundreds and hundreds, probably thousands of these consultations since we started this. But can you maybe describe from where we were right out of the gate versus today?
Yeah, absolutely. So our first foray into this, we really started with it was one solo hospital. It was helping out some colleagues of ours down, like I say, down the road. And it was a little bit more, it was 100 miles down the road. So it wasn't like driving out uh, for continuous stretches of time was very practical. So what we really came up with is um, we looked at options, and I know that there's multiple different types. There's monitors in rooms. There's cameras. There's these essentially robots that we can bring in there. Granted, they're carted in, but they have the capability to give us eyes and ears. Um, it does in terms of the physical exam components. Um, we are able to really you can see very 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 well. They're very high fidelity cameras. It's easy to see what's seeing on a patient. Now it does require that nursing is kind of the hands in the situation to do some of that, but it's a hand in hand workflow with nursing on that one. It gets us a little bit better, I think, image quality, a little bit better clarity. We can kind of move around the room a little bit to see different things if we need to. If you take the eyes out of the equation and you look at what else we actually have ears on this. There is an electronic stethoscope. It does transmit sounds, and depending upon the type of hearing equipment that you use, you can really hear certain things. And you can hear murmurs very well. You can hear, when someone's got crackly lungs, it's, pulmonary edema or rhonchorous breath sounds, or those things that we hear that may alter our treatment plan or treatment course. We're able to hear those things through a stethoscope. Obviously, you don't see what I have in front of me right now, but what I have in front of me is a 3 monitor setup. I'm a little picky about how I tend to look at things because I like to have the patient view in one of these panes. I like to have radiology in one of these panes, and I like to actually have the electronic medical record. So I like to have that remote monitoring. I can look at all the same labs that the site facility can look at. I can look at the images the same site can look at. I can read all of their reports. I can navigate through the system. I can really and enter orders. So we're able to really do a lot of the same type of stuff you would do at the bedside. Um, there are some what I would consider some very minor losses in efficiency by doing it virtually as opposed to being in the room. But again, I would also look at this as is it a significant loss or is it a minor loss? My view on that is it's a very minor loss because it does enable us to do some different things. You know, Depending upon the size of the community, they may have one or two critical care patients. One or two critical care patients is not how you would spend an entire day. So when you look at this and say, well, where's the other opportunity? Well, we did discuss this previously. As I said, we started with one. We didn't stay at one for very long. Within a few months, we were up to two sites that were utilizing service, and you start to get three and four, and pretty soon those minor losses of efficiency really magnifies the capability by being able to cover not just one site, but another site and another site. Being honest, we've got relationships across the state of Nebraska, portions of Kansas, portions of Iowa. We've actually got a pretty established, fairly large network now, in a lot of different places, doing a lot of different things. It's been really a very fascinating process. But again, the device itself probably lends itself to a little bit more personal touch than sort of the eye in the sky, so to speak, like what you have with a VisiQ type of a system. So, when you go into a room, I can look at a patient, but we all know in medicine, occasionally you have to have hard conversations. And sometimes those hard conversations don't happen with the patient. Sometimes those hard conversations happen with families. And instead of having a kind of a monitor on a wall, you're getting um, sort of a man in a box, so to speak, or a woman in the box. But we put that right in front of the family, and we do have those conversations. It gives a little bit more flexibility to how you interact, not just with the patient, not just with the nursing staff, but also with families. So machine capability is actually, I think, a very big portion of some of the success. Feels personal, I guess, is one part about it.
Yeah, so often we hear patients saying, it's just like the doctor's right in the room with us.
And I can't emphasize enough that and you've had dozens of those experiences where you're talking with family members and patients, but it's a huge value. Two things on this that you mentioned. One, in terms of the families, one of the things that we hear a lot from the rural facilities is, and when I say rural, in some cases it's a 150 bed facility that we're in. Some cases it's a 20 bed facility. But in either case, if historically those patients were transferred or sent to another facility for whatever reason, all of a sudden now they're staying there. And sometimes the family kind of goes, no, well, now wait a minute. You just transferred this same scenario or situation, 6 months ago or a year ago. Why now? I still think, isn't the care better in a bigger place or in a different place? And I think it's a huge value add to be able to have somebody like Dr. Martin to come in, whether it's on a cart or even on the wall mounted device. But in either case, you're able to talk with the family and offer that reassurance that, God, really what we're doing here, that's the same thing I'd be doing if I'm seeing him in person in Lincoln. Do you feel like you've had that experience from time to time?
That's a very common conversation. The very common component of this is, and one of the things I didn't really mention that I will kind of come back to just a little bit, when you have the capability of having the amount of information sort of literally at my fingertips while I'm having this conversation, I can share images. I can share, lab values. I can show some of the same things we would normally see. It's really very difficult to do in a patient room in a lot of instances. The quality of a monitor inside of a patient room, or there may not be one there. We're able to actually share some of those things. And really, one of the things I would tell you, and just in general, is if I'm comfortable with it, with someone staying there, the patients are comfortable, and so are the families. The other thing that really helps in those is when we're comfortable with that, we also tell them, if push comes to shove and we decide something changes and we need the transfer, your name's already on the top of the list. We know who you are, we know what you need. If we need the transfer, we actually can do that and have the correct services ready when we need to go. The times when that comes up really center around procedural needs. It's
Right,
it's really
right,
being able to do certain procedures that just simply can't be done on site. And that would be probably the biggest thing that is our need for the helicopter, the ambulance, the transfer. So that's really where I think things get the need for transfer. But for the most part, medicines work the same. It doesn't matter which hospital they happen to be in. And, a lot of our treatments and therapies, they don't necessarily change that much from facility to facility. So, what in a lot of instances we tend to be is an augmentation of the local physicians and an extension of ability in that community. And to be honest, with the way we've developed this, and I know that we're a little different than most, and I'm going to share one of the things that I feel like is different about us. We're not necessarily wanting to just take the patient out of your facility and bring them to our facility. I think that's yesterday's model. The model moving forward is going to be about how do you handle the problems that arise in the environment that you're at, and how do we avoid letting geography be a barrier to really high quality care? How do we avoid those items? And this is how you do it. You do this by being able to utilize cameras and internet access and electronic medical records and digital imagery, all of these things we have. So where we really are at this point, in my view, is leveraging the capabilities that we do have and really maximizing, each and every facility to what they can do. What's their top end? Where is their comfort level? How do we get to the best that we can do there? Um, as you do know, I came from a small town. Many of my family members, grandparents, aunts, uncles still live in these small towns. And I can tell you to this day, uh, they don't really want to leave in a lot of instances. They would rather stay home. Now, that said, they also do know there are times that you just kind of have to move on down the road, and that's what we got to do. But um, really, if we're able to do a lot of medical management or certain therapeutic management, that's a big deal. And then if you look at the local physicians having sort of that, and what I always hope and what we hear from time to time when we get feedback, we don't often, but when we do, it's really nice to have you help us out and sort of point us, just kind of nudge us a little bit in the right direction here, or reassure us that we were on the right track when we were treating. It's again, it's a big part of this, but the program that what we're espousing, what we're trying to do, we're not trying to take patients out. We're trying to keep them home.
Right, and I think that's the key take home, and really regardless of where the patient's at, we do a lot of activities in states far away that if they do have to be transferred, they're going to a different tertiary center somewhere, which doesn't make any difference to us. The key is, can we keep the patients at home? And I'll tell you, the incidentally, by the way, that program that was started 8 years ago or thereabouts, as it relates to those two providers who went to administration saying, "Hey, if you don't fix this, we're going to leave." Those two guys are still there, by the way. So it's
Okay.
been a huge value add to that
Yeah.
facility to retain those physicians because you're able to provide that much needed work life balance strategy, and that kind of coincides with what we've seen on the recruitment front, as you can leverage these types of programs to recruit specialists into organizations that otherwise would be very difficult. And I'll give you an example, and you know this facility as well too. Now this is further out west, but 120-ish bed facility who at the time had zero pulmonary presence at that facility. And talking with administration and over a handful of months, basically led them down this path, encourage them, say, listen, you start this program 24/7, 365, and over time, use this as a recruiting tool to recruit one of your own providers in, and then we could augment and transition a percentage of that care over to the local individual, because based on, and I've been in a lot of CEO discussions with a lot of physicians on recruitment strategies to try and articulate and describe the virtual strategy that they're deploying. And one of the things that often, it's a tough sell, right? To recruit a physician to a rural community and they're in a regional hospital of 110, 120 beds, to say, listen, you're only going to be the guy a third of the time. We promise. We're going to only call you a third of the time. We may not tell you exactly what that third amounts to, but you're only going to be the guy a third of the time. So, and I got it's been another fantastic story where we started the program 24/7, 365, and then they had a physician that was recruited and locked up within about 6, 7 months, and that physician is still there 5, 6 years later.
Yes. So in that case, that one has been a fantastic success story in terms of how that program, that process has worked. It's not just led to recruitment, but it's led to retention. And I can tell you, with the nature of the beast, with what we do, call is not trivial. It is the worst kind of call that you can get. And if you start thinking about 180 nights of call a year, being on every other night, uh, it's really pretty daunting. That's not something that really is something that is easy to recruit to. You also have a limited number of colleagues to refer into, and I would say we have a very good working relationship with this position. Very good working relationship, actually. We share patients quite a bit back and forth. In a case like that, and this is one of the interesting parts, is the size of our group has lent us to have what I would consider some very specialized capabilities, beyond just the concept of general pulmonary or general ICU care. And in that instance, they have very clear early access to some of the very unique things that we can do in our community, that just simply isn't reasonable, whether it's equipment cost. for simple instances, some of the more exotic bronchoscopic techniques that we do, it's a very expensive piece of equipment. In a city like where we're at, we have the capability of and the patient base to do multiple cases per year. You figure you want to do a procedure that's very highly complex, you want to do about 50 cases per year. You know, we have that in this community. However, it's really not viable or feasible in certain communities. So that hand in glove technique where we have a person who we work very closely with, when there's something that is just not feasible for them to do in a remote location, we do have a really easy train track to get that person in and actually do some of these techniques, some of these very technical procedures, and really kind of augment that patient experience as well. So they know they're not just left out in the woods, so to speak. You know, they're not stuck with, well, this is the only thing we can do. We still have access to those things. So it has really been a big deal to have actually local partners. I think is really a major benefit to both sides. When we have those relationships in communities, we have the local individual who really, I mean, running a city doing what we do 24/7, 365 wouldn't really be all that feasible. But having that person that does have that work-life balance and has that capability to be there in the community, and then still have the access and capability to get into the whatever the most specialized piece of equipment or procedure or technique is, we have that.
Yeah, that and that's fascinating stuff on a lot of high tech stuff that you have, and you're absolutely right in terms of really sort of profiling what do you want to be good at your
Right.
facility, and what is it appropriate that you're good at, and how can we augment that and work together to maximize your efficiency and your productivity at the local level and keep those patients there ultimately contributing.
This has been part one of a two-part episode with Dr. Ryan Martin from Nebraska Pulmonary Specialties. Be sure to join us in a couple of weeks where we bring you part two of the conversation. Thanks for joining us.
We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledigmhealth.com. That's pulse@teledigmhealth.com. For more information or general inquiries, please visit teledigmhealth.com.